Everybody. Good evening again. I'm Dr. Pascal-André Vendittoli. I'm an orthopedic surgeon working in Montreal, the past ortho chair leader for Healthcare Excellence Canada. I have the pleasure to welcome you to this webinar on the same-day surgery implementation and outcomes. This webinar was made possible because of the collaboration between Healthcare Excellence Canada and the Canadian Orthopedic Association. You are a big number of people showing tonight, so we're very, very proud. This is a national webinar. So I would like to begin by acknowledging that the land on which we gather is the traditional unceded territory of the Huron-Wendat people. Nous saluons et remercions les divers peuples autochtones qui ont enrichi de leur présence ce territoire, accueillant aujourd'hui des gens de partout dans le monde. Some more information on the webinar. It is accredited by the Royal College of Physicians for 1 credit. At the end of the webinar, you will receive by mail an evaluation form. Please fill it. It will help us to improve next sessions. And this webinar is recorded and will be publicly available in the next few days. Please use the Q&A box to send questions to the speakers, but the participant microphone will be mute for the duration of the webinar, but there will be plenty of time for a question after each talk, and also at the end of the webinar, we will have about 20 minutes for answering the diverse questions that you may have. We have a nice agenda tonight. The webinar will focus on specific aspects of ERAS-outpatient program. We'll start by talking about patient optimization, which is the key to succeed and avoid problem after surgery. Then we'll see what are the hurdles when implementing such a program in your center, the factor of success of implementing an ERAS outpatient program, how to avoid failure, and also to keep in mind that the main goal for us and for the patient is their satisfaction. So let's start with me discussing the optimization of patient for same-day discharge in ERAS, THA, and TKA. It is a topic very important for me, and I spend a lot of time trying to improve my patients. First, I would like to disclose two relations I have. One is with Johnson & Johnson, where I did consulting work regarding ERAS hip and knee replacement protocols. And also, I was the past president of the ortho chair leader of Healthcare Excellence Canada. As you may know, ERAS principle is the perfect option to bind with outpatient procedure, because our goal with ERAS principle is to improve the patient outcome to a level where he is ready to go home sooner and safely. It requires multiple interventions. It is linked to the multimodal concept. Not all interventions are needed for every patient, but needed for the success of the entire cohort. Preoperative optimization is one of the key factors of this multimodal protocol. It includes education, modifying the risk factors, looking for allergies, trying to improve personal habits, drug management, and also pre-adaptation. It is a real care personalization for each patient. All that content I will discuss today is available in the clinical pathway for inpatient and outpatient hip and knee arthroplasty resource. It can be found in the Healthcare Excellence Canada website. It is the result of a consultation of 20 experts across Canada, as you can see here. Preoperative education and patient engagement is very important. On the day of surgery, there is no time to explain all the procedure. Patient and the caregiver education on the program is very important. You should explain the course of the ambulatory day. inform the patient about the drug he will receive and their side effect, and also answer all their questions, because it will increase trust, and also patient will know what will happen on that very important day for them. If you can, is to the best is to create pre-operative education session, and also provide them some booklets, information booklet, where they could rely on and read before the day of surgery. A well-prepared patient will experience a decreased anxiety level, will take fewer pain medication, and undergo a reduced hospitalization time. One very great resource that you can have on internet is a precare.ca. This internet site includes all the ERAS pathway for hip and knee replacement, which are easily understood by most patients. It's available in English, French, and other languages. And I would suggest you to have a look if you never looked at this great website for free. Health optimization, very important. First, you need to know your patient. A very detailed medical questionnaire should be filled by the patient, and all this information should be used by the team member throughout the patient pathway. Lab tests, EKG, radiograph, and also specific questionnaire are very important to include in your pre-op assessment. Specific interventions that needs to be done before surgery. One example is review selection and inclusion criteria. Last intra-articular injection should be, for example, more than 3 months before surgery. This is a simple thing to look at, but very important to prevent post-op complication. Evaluate the patient level of anxiety and willingness to collaborate is one of the major factors of success of outpatient procedure. Patients who are very anxious may be the most difficult one to discharge from hospital. Identify patients with chronic opioid use. This is a major impact on post-op pain, so you should suggest them to reduce or discontinue opioid use before surgery. Inform the patient about the risk of tobacco or alcohol consumption, and provide the cessation tools if they use one of these drugs. Last, identify patients with chronic anxiety or depressive disorder. These two psychiatric problems should be taken care of before the surgery. Diabetes is a very important factor to identify before surgery if the patient is an unknown diabetic. If he's a known diabetic, please try to optimize his glucose level. You want to reach a HbA1c of less than 7.5 before surgery, because you know that the poor glycemic control during surgery or after surgery relates to increased infection rate and poor healing of the wound. Education, provide pre-op documents to know what they should eat to reduce their glycemic level. Identify factor of remote infection, problem with their foot, ulcers, all the disease the problem linked to diabetic. Adjust the corticoid that you give peri-operatively, like dexamethasone. We reduce the dose to 4 milligrams for our patients to improve the glycemic control after surgery. If the patient is inpatient, you may want to use insulin chart post-op to control their glycemia. Hematology, very important preoperatively to improve their hemoglobin level above at least 125 or better 130. We know that 70 to 80% of our patient anemia is linked to iron deficiency. So very easy to treat with some iron orally or IV before surgery, most of them should raise their hemoglobin level above the 125. If not, you should use a more effective drug like Eprex, or delay surgery until you are able to improve their hemoglobin level above 125. Doing so, you will minimize the risk of transfusion and all complications linked to it. In combination with tranexamic acid at our clinic, at the Duval Clinic, in 2022, with more than 1,000 cases, only 3 patients required blood transfusion at our clinic. So this is a major impact on the quality of care. History of thromboembolic disease should be seek, and people with DVT, PE, we should postpone surgery for at least 1 year after the event and prescribe thromboprophylaxis based on this history. Avoid tranexamic acid for these patients at risk of having another event after the surgery. People with venous insufficiency, as you can see here, very severe quality of skin. Please try to cure these problems before surgery with compression stockings and avoid the post-op problem with the false cellulitis. Allergy intolerances need to be looked at before surgery, especially the drugs that are included in the protocol. We know that giving a cephalosporin is very important to prevent infection. So please make sure that any history of penicillin allergy is really linked to an anaphylactic reaction. And in the if you're not sure about, please ask an immunology consultation because this is very important to as a drug to be given to prevent infection. Allergy to sulfa, you need to change celecoxib for another anti-inflammatory, for example. Malnourishment, very important because it increased infection rate, wound healing problem. So be aware of the patient after a bariatric surgery in the last 2 years. There are multiple screening tools available. Please use them to then treat the patient before surgery and send them for a consultation with a nutritionist. Pulmonary risk, look for that, asthma, sleep apnea, and also risk of pulmonary aspiration. You know that today with the new drug, very popular Ozempic, it is linked to that complication. So you may need to stop this drug about 3 weeks before surgery. Please, I refer you to the Canadian recommendation just published last summer. Cardio, please identify the unknown disease patient and optimize their cardiac condition before surgery. Urinary system, very important also to prevent post-op infection, prevent the urinary retention risk. If they have prostatic symptoms for the men, you can use tamsulosin pre-op, and this will help prevent the use of catheter after surgery and will prevent any failure to discharge. Personal drug, please look at each of the drug that this patient is taking, use a specific recommendation for these drugs, and refer to internal medicine doctor or pharmacist in your hospital to really tell the patient when they should stop their drug before surgery and when they should resume it after the operation. Optimization may take time. You should start investigation and this optimization at least 4 weeks before surgery. And if ever disease need to be optimized, please delay surgery. And this is the real, again, personalized care plan, and the patient will be the beneficial of this improvement for him. It is an improving your ERAS protocol involves multiple steps along the way. Optimization is one of them, and this can be done anytime during your protocol optimization. Again, I referred you to the link of Healthcare Excellence Canada, where you can find all these the documents you can download in the Precare website. And this is what I had to share with you on patient optimization. We may take a few questions before moving on to the next speaker.
Thank you, Dr. Vendittoli. Just as a friendly reminder to our attendees, you can use the Q&A box to submit any questions you have. That's at the bottom of your screen or at the right-hand side of your screen. And so we have our first question here. It's, with a history of VTE, do you consider giving topical TXA instead of IV? If so, what dose?
It's a very good question. Honestly, we don't use topical tranexamic acid in the patient with a history of VTE. We believe that the risk-benefit is not clear, but if you have information, or I don't recall any clear publication that looked at that aspect right now.
Thank you. And our other question is from Arimita, and it's, could you share references or evidence for positive outcomes on reducing or discontinuing pre-op opioid analgesics use and the guidance of how to achieve this? Thank you. Sorry.
Yes, very often in my practice, patients are taking opioid before surgery because they were prescribed opioid by their general practitioner. And when I take the time to discuss with them about the impact of using opioids, most patients understand very well the benefit of stopping opioids. In the literature, there are a number of papers that created the correlation between opioid user and poor postoperative pain control and outcome. But I'm not sure there is currently a paper looking at the effect of stopping opioids on the outcome. This would be a great study.
Awesome. Thank you. Another question here. Post-op, when would you recommend to restart Ozempic?
Currently, Ozempic can be restarted as soon as the patient is able to eat normally. So it could be the day after surgery. The main risk of Ozempic is really the slow let's say stomach output, and it is really unclear now when it should be stopped before surgery. US recommendation is the day before surgery. Canadian Anesthesia Association is 3 weeks before surgery, and this is to prevent aspiration during the surgical procedure. But after surgery, it can be resumed the day after.
Thank you, Dr. Vendittoli. So for now, we'll move on to Karina, but we will have a question and answer period at the end of this session. Thank you.
So next speaker is Karina Pellei. She's a physiotherapist working at Hôpital Maisonneuve-Rosemont in Montreal. She did her master degree on the implementation of an enhanced recovery after surgery program for hip and knee replacement in 2015. And she was the ERAS leader at the hospital in those years. So she has a great experience on the hurdles of implementing such a program in an academic center. So Karina, please, we'll listen to your advices with a lot of interest.
Well, thank you for all being here tonight. So I'll start with the hurdles when implementing an ERAS-outpatient program. I have no conflict of interest to declare tonight. In the few slides we have, we'll discuss that subject. I'm sharing tonight the systematic review, first published by Stone and Al in 2018, shared with me by Debbie, your next speaker. We will focus more on the right side of the columns, the barriers to implementation. I'll explain to you a few that we experience in more details. and also explain a bit to you how we started that project, so you have a little bit of history on how it worked and why we faced those hurdles that we did. We started in 2015, obviously by researching all the evidence base to manage the best possible way the pain, nausea, orthostatic hypotension, bladder retention, hematoma, wound discharge, loss of motor function, anemia, DVT, and infection, which are all complications that can happen after surgery, during surgery. We want to manage them the best way. So we research for you the best evidence for you. And we actually created the booklet that Dr. Vendittoli just talked to you about. We have to do as a team, set a goal. We have to set a goal to be able to do the outpatient surgery. So we discussed with all the members of our team, and it's really important that you work as a team and everybody has to be on board to define the type of day surgery program that you would like for your center, private or public. You have to be there as patients, nurses, physical therapists, administrators, surgeons, and anesthetists when you work as a team, and everybody needs to be on board, as I was telling you. In the practice standardization, you can include patients that are obese and not be afraid of including them. Patient over 7 years old, of course, you need to know their medical history to be able to include them. People living far from the hospital is also possible, but near a hospital, if it's not the hospital where you work from. And the nursing staff, you also need to manage the pain that the pain medication that the patient is going to take needs to be taken orally. And sometimes it's a subject you need to discuss with your team, because when you give medication after surgery, sometimes we tend to do it in IVs or subcutaneous medication. And it's better if you give it orally if you want your patient to leave at night. Also, the anxiety that is associated with standing a patient up the first day of surgery. And it's heavy cases when you talk about surgical surgery, hip or knee replacement. Training is good for your staff. They need to know what's going to happen. And there's anxiety, of course, related to that. In physical therapy, you need a physical therapist available. That is at the end of the line, of course. The work schedule is a problem sometimes because it's late hours. It's going to be at night, so you need one that is going to be available at night after the shift of most people that go home. The anesthesiologist is going to have a change of practice because there are less opioids given. Some medication is going to be changed, and we don't want a femoral block either. So there are a few changes there. Surgeon have sometimes changed their way of closing the wound. And also what helps a lot is having physician order templates that you can adjust depending on what your team is wanting to do. As I was talking about the time of surgery, it can sometimes be a problem, the timing. If you work in a public system, which we had when we started, of course, it happens that the patient leaves the recovery room pretty late. And that way the physical therapist cannot see the patient at the right time, and the patient cannot be discharged. Sometimes there are administrative problems, and sometimes it's the patient that doesn't do well. It happens. But if you can, you try to have your patient come out of the recovery room or the OR before 2 o'clock so that the patient can leave before 8. Here are a list of exclusion criteria that you can standardize in your practice. As I was saying, what works for you, and of course the medical history of your patient is very important. And Dr. Vendittoli just explained them to you. So I'll let you read it a little bit and then go to the other slide. The pathway includes, of course, physician templates that you can have. It's a standard for everybody. So everybody follows the recipe, it's easier. When you want to do a fast track surgery and you want your patient to leave the same day, if everybody does the same thing, it's easier. So you know where to go and what to do. And sometimes when you change the team or you change your person and you don't have those templates, it could be harder to just follow the recipe book. So here is also the link Dr. Vendittoli gave you. You can find the recipe book we had when we started. It helps a lot when the team changes, the team members change, so everybody knows where to go and what to do. A few of the things you need to also think to not have problems in the OR is that you might need special medication as if you want to do infiltration. And we also gave large doses of medication into the joint around the tissues that were sometimes questionable for the team when they didn't know that kind of protocol. There were publications on it to help reassure the team that it was a safe technique. It helps with pain for the patient, and you can see it at the end of the line when you're a physical therapist and you get your patient up, you see a difference when they had their local infiltration because they have less pain and it helps them move and they can go home and they are reassured because the pain is well managed. Other things you need to take in consideration when you have a patient that goes home the same day and you want medication taken orally, it needs to be available. And we actually had that small problem when we started because there were no oral medication in the recovery room, which you need to think about because you don't have that. So you have to have it available. Of course, you want to remove all the catheters, and the patient needs to eat as fast as they can, a normal diet. The personnel needs to be available on time. As I was saying, you need to be available to get your patient up and moving and get dressed and then go home. We want the patient to be safe, and it's also helpful when you have people available to just take care of that patient and when they have someone to reach to help them go home safely, and just reassure them when they have small questions, someone available, phone number that you can leave that patient so that they can reach you. The role of a leader is really helpful when you need someone to know the protocol and just know where to go. It helps with all the small problems sometimes you can just be exposed to. So here's a list of what a leader could do in helping you in being the maestro in your implementation and not face the hurdles we had. In summary, here's a list of the pain management we had during our implementation. Before the surgery, the anesthetic protocol that we used, the surgery, what was changed during the surgeon part, and also at the end when the patient was going to the recovery room, we were giving oral medication and also ice to help them with pain with special machines with compression. It's a compression therapy with ice. Nausea was dealt with limited fasting, preemptive medication, opioid-free, of course, as we are telling you, and early normal diet. We avoided as much as possible opioids. Early mobilization, the anesthetist was using a protocol that was helping the patient move fast. No femoral block. The patient was able to move safely with a walker or a cane. Sometimes they were walking without aid, so that was pretty amazing. The orthostatic hypotension was dealt with the anesthetic we chose, and also with local infiltration helped with pain, so no opioids, and they were able to move easily. And motor function, also no catheter, no drain, and the IVs were removed post-op. The DVT, special medication, infection, special medication, also antibiotics, prophylaxis. And you can all find our protocol in this link. And these are all the experts that helped develop all that. And I think my question period is right after Debbie, and I'll be sending you to her after me. Thank you.
Thank you very much, Karina. We'll keep the question for Karina after Debbie Watson presentation. Debbie is a nurse care pathway coordinator at the MUHC and since 2008. Now she's working at the provincial level to implement ERAS throughout the province. So Debbie will present us on the factors of success to implement an ERAS outpatient program. Thanks, Debbie. I will give you the microphone.
Thank you. Everybody hears me? Yes, I guess. I'm off mute, right?
Yes, we can hear you. Thank you.
Thank you. Okay, so here I go. So I'm going to give you really a broad view on the factors of success to implement an ERAS outpatient program. Oh, how do I move forward? I have nothing to disclose. I have 8 minutes to give you this presentation. So when I started to prepare my presentation, I really wanted to know what does success really means. So according to the Webster Dictionary, the definition of success is the degree or measure of succeeding, favorable or desired outcome. A synonym of it is an achievement, a successful result brought about by hard work. So if I measure, the measure of succeeding depends on the objectives I set. For example, if I plan to have 15% of all my hip and knee arthroplasty done as day surgery, and I do reach this, well, I think I'll be successful. However, if many hospitals around me are reaching 60%, well, then perhaps I might have to reevaluate my objective. And going back to hard work, well, I don't know about hard work, but it's definitely teamwork. So my first factor is a strong multidisciplinary team with good communication. So the qualities of the team members, they should have leadership skills. They should be able to motivate people, to influence, to listen, to be positive towards change in general. Personally, I really appreciate when my team members respond to my emails in a timely manner. Why? Because this helps to keep the momentum going, keeps us going forward with the hard work. But generally speaking, the team is composed of an anesthesiologist, for sure, plays a huge part in this program. The surgeon, a nurse, physiotherapist absolutely plays a crucial role. So I would definitely include physiotherapy right from the beginning. Having regular team meetings to discuss the order set, the protocol, to make sure you reach consensus amongst the surgeons, the anesthesiologists is extremely important. Having a coordinator part of the team, I believe also influences your success, which brings me to my second factor, involvement of a full-time ERP coordinator. Now, this is a publication I wrote a few years back in nursing management, and I wanted to describe the role and the task of a coordinator. So I'll just name a few here. So what does an ERP coordinator do? So they can do lit review on different subjects. They can write draft orders with the experts. They finalize the order set. They send it to the approval committees, right? We all know that hospitals have approval committees, and they can manage this back and forth between the committees and their experts. They need to know the patient process from beginning to end, and they will know who to speak to, where to provide education to staff. That person also is someone that is familiar with the health literacy concept. That person will be able to write patient education material in plain language, will integrate images and illustration only to add comprehension of the text. That person will audit, will share results with staff, will highlight what needs improvement according to the data collection, and will also help to celebrate the success. In general, I truly believe that the coordinator will let nothing fall through the cracks. Effective use of implementation science. be strategic when you're going to implement your program. Don't let chance determine the success of your program. When I started at McGill in 2008, I thought that, hey, I'm going to provide a lot of education, and I will not be facing resistance. Never mind, at McGill, I was very lucky. There was very little resistance. However, education is for lack of knowledge. That's when your champions, your leaders are there to motivate, to influence, when you're going to start facing resistance. You might not, but in general, this program is an organizational change. And when you have this type of change in a huge organization, you're bound to face a little bit of resistance. Another strategy is visual cues. So for forgetfulness, you have visual cues for reminders. Now, right in the middle, you see a logo here. It's a Center for Implementation. This is a Canadian company, which I really love. I have nothing to do with them. But if you're not familiar of how to deal with barriers, how to go about with your barriers, look them up. They provide strategies. They will help you. They have several free courses. And I highly suggest, if you're new to all of this, follow a few of their free courses. It will definitely help you to bring change in your organization. My next factor of success is standardization of a protocol. So it's another factor of success, but it's also an element that will help your sustainability, right? You don't want to do all of this work and then you can't sustain it. So keep in mind, having a protocol that everybody uses it will sustain your program. You'll need to think about to review and modify your protocol every 4, 5, 6 years, or whenever there's new literature that comes out that could improve your pathway. Think about, and it's already been mentioned, inclusion criteria, exclusion criteria. But I have to say that when we started several years back at McGill, perhaps our exclusion criteria was a little bit lengthy, and still with safety in mind, I think that it has decreased a bit, and that's normal. You will gain confidence. You'll see that this is working and that patients are able to go home safely. Having a protocol and defining discharge criteria also decreases variability in care, leaves no place for interpretation. Reaching consensus, and I'm repeating it again, reaching consensus among surgeons and anesthesiologists is important so that everybody uses that protocol and follows it. Adherence to the protocol. I say protocol, but you could have orders. I usually like it to call it a care pathway. So adherence to your care pathway is crucial. But how will you know if you're compliant with the different elements if you do not audit? So my next factor of success is continuous auditing and feedback of results with frontline clinicians. It is said that 70% of projects fail because there's no sustainability strategies put forward in the beginning of a project. So continuous auditing and feedback of results with frontline clinician is definitely a factor influencing success for an ERAS program, but it's also a factor that will influence sustainability. You should audit process variables and outcome variables. Here are just few examples, but I also want you to be very mindful about choosing your variables because it's resource intensive to go through charts and to get data and look at all those variables. So pick them right. A process variable will evaluate whether the recommended intervention is being followed. An outcome variable determines if a specific intervention is having the desired effect on a clinical measure. I had to add patient-reported outcomes, which they can be a little bit more trickier to find in the chart, but it's something I believe that we're going to see more and more of, and they're very important. They're rich in information. So exactly what the slide says here, what is not measured cannot be improved. So if you don't know the reasons, especially that's what I wanted to say. If you don't know why patients cannot or are failing to go home on the day of surgery, you will not be able to put interventions in place addressing these specific reasons. If you don't know the reasons, you'll not be able to modify and improve at any phases, whether it's pre-op, intra-op, or post-op. And that's really what you're aiming for, right, in this type of program. My last factor, and it's a subject that I love to talk about, so I'll make it quick. It's a patient engagement and education program, okay? I believe these are important as the order set. Everybody has had to read them, reach consensus also for that. So on your left, you've seen them before, are the booklets that come from Healthcare Excellence Canada. On the right, it's the McGill one that my team and I created. It's for our day surgery program. Now, there's several advantages of getting that, okay? And I'll name just a few. You have new nurses on the floor. They're supposed to do discharge teaching. Not sure what to say? Well, very easy. You go at the at-home section, managing pair, caring for your incision, and so on. It decreases variability. And also when to seek help or go to the emergency room, I think it's very important. All the team members need to review the content. Getting feedback also from a few patients also helps to ensure that content is clear and that patients comprehend it. Of course, they have to be written in plain language. And if any of you think it's easy to write in plain language, you're wrong. It is quite difficult. We tend to say a lot more than we need to. No medical jargon, no acronym. I can go on and on. Think that health literacy in Canada is low. We are losing our patients by what we're writing. Now, two companies here, Autrement dit and Precare. I think we've already mentioned Precare. We use them at McGill to do our booklets. They're full of beautiful animation also. Autrement dit is a Montreal-based company also that can help with plain language editing. I just wanted to show them. I have nothing to do with them, but they can be very, very helpful. So to recap, my factors of success to implement an ERAS outpatient program is your multidisciplinary team with good communication. 2, involvement of a coordinator. 3, effective use of implementation science. 4, standardization of a protocol. 5, continuous auditing, and definitely patient education. And that's about it. Thank you.
Thank you, Debbie. So now we have 10 minutes to ask our questions to Debbie and Karina. So I'll ask you both to come on screen and Dr. Vendittoli as well. So our first question is for you, Debbie, I believe, and it's what do you consider exclusion criteria? And is this specific to practitioner or to patient risk factors?
Yeah. I think Dr. Vendittoli mentioned them before. Was it Karina? There was exclusion criteria, people that you should consider perhaps being admitted and not being in day surgery. I don't think age is a factor anymore because you can have 80-year-old people that really are fit and they look like they're 40. I don't know if I said 80 is a bad one. I don't know them all. Okay, I'll give you an example. An exclusion criteria is somebody that's living alone and at home and does not have anybody to be with them to give them help for the first 24, 48 hours. That would be an exclusion criteria.
Thank you. Okay, our next question is, who does the check post-op in the community? Is it at your facility or do they go to another private PT clinic?
Who does
that one?
Yeah.
It depends where you are from, but in Quebec, we have CLSCs that go home in a few of our areas. Not everywhere, but in Montreal, we're able to have them go home. Outside Montreal, sometimes the patient needs their family to be driven to that center, but they see them in their center or at home, depending of where they live in Quebec.
Thank you. And Debbie, would you mind just stopping your share screen, please?
Yes.
We'll see you better. Thank you so much. Okay, our next question is, what degree of obesity is an exclusion criteria?
That's a good one. Maybe Dr. Vendittoli can answer that one.
You know, the exclusion criteria are very variable. The better is your protocol, the better is your team. These criteria are shrinking. Over the years, we started 2015, all these criteria just reduced. And at the end, I think the main criteria that we keep is the motivation of the patient, the availability of a caregiver to help after surgery. And we operated patient of more than 80 years old in outpatient surgery, patient with BMI of 50 in outpatient surgery. It's the more your team become expert, there is a lot of feeling that assessing a patient, seeing his motivation, his environment, caregiver help, it makes a big difference. So that's my, I think that everybody should have a base on exclusion criteria and then review them every maybe year, 6 months over the process.
As long as you get more used to what you're doing in your hospital, it's easier also. Because we all started, like we started with small BMIs and then went up. So yeah.
One question that comes all the time, it's in the Q&A section. People with sleep apnea, are they a candidate for outpatient surgery? In fact, if you're good, if your protocol is efficient, these patients will not need opioid after surgery. So doing outpatient surgery ERAS is probably safer for them than keeping them in the hospital and receiving hydromorphone, subcute, for example. So again, these exclusion criteria just were removed from our list one by one.
Thank you. Another question we have is, do your same-day patients usually see both physiotherapy and occupational therapy?
They don't see occupational therapy because usually they see them beforehand. They're able to see them before the surgery, a few months before. Depending on which physical therapist or occupational therapist does it, they see them at home. They do an evaluation of what they need for equipment. Sometimes it's also the TEFIS in Quebec technicians that see them before surgery. Occupational therapy is not really involved in our environment. I don't know for you, Debbie.
No, not really. Not
It's usually physical therapist that does the evaluation before and after. Sometimes you have OT, but since there are a few of them and there are not a lot, they're not available to do evaluation. So physical therapist and technician here does the job for evaluation and after surgery, before and after surgery.
Thank you. Another question we have is, what percentage fail to go home the same day and why?
You answer that one.
It's again the Karina, you know the number. It's the quality of protocol. Please answer.
Well, it's actually what we did. There were only a few that didn't leave. Remind me the numbers. I forgot the number, but it was only a few. I could count them on my hand. We did over 125 patients, and only I think 9 of them were when we did our research. Was it 9 of them that weren't able to discharge, or 5?
In the research, there was 3% of hip replacement that were not able to leave on the day of surgery. And to give you an overview, there was a recent publication this year by the HSS, Hospital for Special Surgery in New York, the best orthopedic hospital in North America, and they published a paper with 35% failure to discharge. So even in the best environment, the protocol may not be excellent. Fine-tuning your protocol, attaching a lot of importance to some details, play a big role. So if you do half of the job, you will get a lot of failure to discharge. But the more and more you'll be successful, you'll be more predictable. It starts by patient selection, all the protocol implementation, and the teamwork. As Debbie said, teamwork is the key to success.
Thanks. We have so many interesting questions coming in. I think we'll save them for our Q&A at the end. So we'll continue with Dr. Hardy.
Okay, so next talk will be very interesting and following on the same topic. Implementing an outpatient protocol is very important for the environment, the administrators, to have reduce the cost. But for the patient, we want to avoid a failure. A failure for the patient is very stressful, not being able to leave hospital, being home and needing to return to the ER, emergency room, because they have a complication or a significant problem. Dr. Bheeshma Ravi, after the COVID pandemic, published a paper looking at the problems of the patient needing to return to the emergency room. So Bheeshma Ravi is an orthopedic surgeon working in Toronto. Please, Bheeshma, share with us all your findings on that topic.
Thank you, Dr. Vendittoli. I'll just share my screen. So as Dr. Vendittoli said, my talk is looking at how to avoid readmissions and emergency room visits after outpatient arthroplasty. I don't have any conflicts of interest and nothing to declare. As we all know, and obviously we're all attending this talk for this reason, same-day surgery for hip and knee replacement is becoming very popular, and I think from something that was considered rare, it has become very mainstream, and in some hospitals, the primary way arthroplasty is delivered. The data I'm going to show is mainly from Ontario, but I think is likely relevant for across the country. You can see that the rates or the proportion of arthroplasty procedures that are same-day procedures have really increased from pre to post-pandemic, and if we did it looking at 2022, would likely be over 25%, maybe even over 30%. The rates are really increasing, and not just in hip replacement, but also in knee replacement. Now, initially, outpatient procedures were performed in fairly healthy, fairly robust patients. These were patients with good phenotypes, good protoplasm, as it were, maybe disease isolated mainly to the joint, but systemically, otherwise they were okay. Good family supports or supports at home, and very likely to be able to recover quickly. As hospital pressures and the pressures of the healthcare system and limitations, etc., drive more of our patients towards the same-day pathway, the indications are going to expand. We will eventually be operating on people with more and more comorbidities, perhaps people that don't always have support structures at home, and as such, we can expect that there are going to be more failures. Looking at same-day patients in the study and in the over the time period I just showed in that graph, these patients were younger on average, of a median of 5 years younger than inpatients. Often didn't have any comorbidities, very unlikely to have a BMI over 40, in many cases not over 35. And this health profile was reflected in having fewer emergency room visits. Interestingly enough, all arthroplasty, at least in Ontario, has presentation to the emerge within 30 days of something on the level of 13 to 15%, which is obviously fairly high. The same-day patients tend to have it on the level of 9 to 10%. But as I suggested, as outpatient surgery becomes more common and the indications expand, we can expect that the number of failures will increase. And these failures are not just needing patients that need to be admitted, so they're transferred from an outpatient to an inpatient, but those that go home and then return to an emerge, which in some ways you could argue is worse, not only for the patient, but also for the healthcare system at large. Between 2016 and 2022, this is again in Ontario, approximately 12% of patients that were slated for an outpatient arthroplasty, that is, patients that were planned to have an outpatient procedure, had to be formally admitted. And patients, risk factors, I apologize, risk factors for needing to be admitted were patients of female sex, frail patients, those with increased comorbidities, so more than one comorbidity, not just hypertension, but maybe hypertension with pre-existing renal disease, or hypertension pre-existing heart disease, hypertension and sleep apnea, etc. And those with class 3 obesity or higher, so that's BMI more than 40. And so those patients were more likely to have to be admitted. But beyond being admitted to the hospital, there's also returning to the emergency department. We've looked at this in the past, and there are several factors that are associated with patients returning to the emerge. There's age. Interestingly enough, patients in the 50 to 70 year group, which tend to make up the most of our arthroplasty recipients, are less likely than patients that are younger than 50 or patients that are older than 70 to come back to the emerge. Male sex, several comorbidities, and also patients with lower income neighborhoods or rural residences. And all of these kind of make sense. Obviously, if you have a lot of comorbidities, more issues are likely to crop up after a major surgical procedure. And if you live in a rural area or in a low income area, you may have issues with primary care and not being able to see your family doctor in a timely fashion. And as such, you may use the emergency department as your primary care, unfortunately, for dealing with the smaller issues. Younger patients under the age of 50 may have unrealistic expectations about the amount of pain, etc., that they might expect after surgery. And patients older than 70 may or may not, perhaps less likely to have all the support structures necessary to help them after surgery. I can't fully explain why men are more likely to come back to the emerge. I'm sure some of the other panelists will have theories on that. If we look at why patients return to the emergency room, there are several reasons. Some are quite understandable. So these are people that come in maybe with chest pain, etc. And so possible cardiovascular diagnosis or a possible issue with GI, maybe other issues that are related to some kind of a medical condition. But more often than not, the vast majority, that's close to 60%, maybe 70% of the issues are related to the surgery itself and are often things that could have been dealt with a phone call or more appropriate patient education. So there's either an issue with the wound. Oftentimes it's something like the dressing is red, or there's some more bleeding, or the dressing is not secure. They're concerned about infection because the limb is slightly red or erythematous, and a lot of times it's because of acute pain. I should add that of the patients that go to the emerge, the 12% or so, less than 0.5%, so less than 0.5%, are actually admitted. So more often than not, these patients go to the emerge, they spend a lot of time there, but they're not presenting with anything that requires admission to the hospital. In my own opinion, and I think that's reflected in some of the other talks that have been given already, a lot of this comes down to patients' expectations versus reality. I think as we make a push towards outpatient procedures, which is very positive in my opinion, there's also the issue that some patients may not take on board that they are still having fairly significant surgery. You know, they're able to get up and move right away, but the surgery is going to hurt, and it may not hurt right away. It may hurt later. There are a lot of things we require from them in terms of rehabilitation, etc., that will likely create more pain. And if a patient is not prepared, and perhaps more importantly, if their care structure at home is not prepared, as in their family friends, etc., that are going to support them after the surgery, if they're not prepared for the fact that this is still a fairly significant surgery, then patients are more likely to have to come back because of the variance between what they expected and what is happening. At the Holland Bone and Joint Program, which is the largest provider of joint replacements in Ontario, we try to use a systemic approach, as detailed in the other talks, on patient education. After a patient is referred to our hospital, they're usually triaged in a rapid access clinic and seen within a few weeks of the referral. At that time, they are triaged by an advanced practice physiotherapist and other team members that work to assess the patient, determine what their expectations are, what their goals are, and then refers them to a surgeon. At the surgeon level, we then determine whether or not we're going to go ahead and do the surgery. Then they have a pre-admission clinic, obviously the surgery, and the transition to home. And at each step, we try to remind them of two key points that are relevant. One is that same-day surgery is very safe, and they are more likely than not going to be going home the same day. And two, that this is still major surgery that needs to be respected. So we encourage them to use appropriate pain control. We encourage them to have appropriate support structures in place to ensure that once they go home, they are supported. And this message is reiterated at every step. So at the rapid access clinic, when they see the surgeon, when they see the internist or anesthesia in the pre-admission clinic, including the nurses in care there, after the surgery, when I round on them, or when the nurses are taking care of them or doing discussing wound care, etc., on the floor. And once a patient goes home, we support them with additional phone calls on post-op day one, and further phone call by a member of the nursing team a few days later. We encourage them to contact our office directly. Most of my colleagues will ask patients to email us directly, or suddenly email our administrator if they have any issues, in the hopes that we can answer any questions. And so at each step, we really work with them to not only educate, but answer their questions, and also stay on point with the messaging. As part of our work in the preoperative education class, I think this is very useful because it's a 90-minute class that's run by an occupational therapist, a physiotherapist, but also a previous patient who can then tell them about their experience. And I think Karina had mentioned that, you know, we in the medical profession will tend to use a lot of medical jargon, whether we realize it or not, but a previous patient can narrate their story in a way that another patient can relate to more easily. We also offer virtual physiotherapy subsequently, but I apologize, that's a later point. But the preoperative education class can be done in person or virtually. And again, it's just giving the patients multiple ways of receiving the information. So they get booklets, they get information through an app, which I will detail in another slide, and also through virtual programs online. So as I mentioned, we have a call from the surgeon the day after surgery, and then a post-discharge phone call from our nursing team 48 to 72 hours after surgery. And we encourage patients to contact the office, ideally via email, because obviously it's very hard getting through to busy practices on the phone, but via email. And it then falls to the surgeon and their team to be fairly quick in responding to patient queries. We at Sunnybrook have created an app, initially spearheaded by my mentor, Dr. Golish, the My Hip and Knee app, which is you can download from the App Store, and I think on Google Play as well. It's developed with Seamless MD, and basically it is an app that provides patients with a lot of direct information on their phone, pre-op reminders, but also post-operative information like what your dressing is, what a typical dressing would look like on post-op day 3. And more recently, we do prescribe opioids for patients when they go home. So questions on, or sort of frequently asked questions on opioid use, etc., after surgery, and what is normal, what is not normal, when should you be concerned, points of that, which I think is really useful. Even in the course of my own practice, starting at around 2016, I have noticed that the demographics of our patients are changing, and more of them are comfortable using their phones, which may not have been the case 10 years ago. And this is how they get information. So oftentimes they may not always read the information given in a book, but they are definitely looking at their phones. And this app is a great way to reach out to them. This app has daily health checks, allows us to track their recovery. They receive recommendations, as in, when to contact their surgeon or speak to their family doctor, etc. And there are videos and pictures on how to do the exercises. So I think this gives the patient the feeling that they are still monitored, that they are still involved, that their surgeon or the surgical team is still involved in their care and can act as a useful adjunct for these patients that are home and not getting that inpatient therapy that they may have received several years ago. Patient feedback has been very positive for this program, and I think we're continuing to see an uptick again as our patients become more tech savvy. And overall, patient satisfaction and experience is very positive, with 2/3 of patients indicating that it prevented at least one, in many cases, several calls to the hospital because the information they needed was available on the app. In summary, I think ED visits are generally unnecessary. In terms of admission to the hospital, that will likely be variable across different centers. I think, as Dr. Vendittoli said, some places will see higher numbers than others, but it really depends on how well you're implementing the protocol, but also the types of patients you're getting. If you're getting healthier patients, it's less likely. If you're getting less healthy patients, it's more likely. Consistent messaging across the surgical team is very important and across the entire surgical care pathway. And finally, it's very important that we still set realistic expectations. We want them to know that it's safe to go home right away, but they've still had major surgery, and as a result, they may still have some issues afterwards, and pain is normal. Thank you.
Great. Thanks, Dr. Ravi. So a lot of great questions are coming in. One of them being, what would you say are the areas of, sorry, I'll start again. What would you say are the areas of highest yield to make the biggest difference in success rate of same-day home discharge for teams working in rural and therefore lower resourced hospitals?
That's a big question. I mean, it might be better for Dr. Vendittoli. In my own opinion, I think in that setting, I think patient selection would be paramount. Patients that live in rural areas may have variable patient support, and you may not always be looking at the healthiest patients. So someone that have more comorbidities, etc., is probably not someone I would triage for same day, at least at the start of the program. I think initially the program has to be, at the start of the program, you're kind of training your hospital and your system. So you want to pick ringers or patients that are healthy and you're more likely to have success before you scale up to more complex patients. Dr. Vendittoli, do you have anything to add?
Yeah, it's very clear, but the rural hospital, I don't believe implementing ERAS principles, you don't need a lot of resources. You just need to do it correctly, having the right people, availability, having a person available to answer patients if they call back the hospital. Having a patient available to answer questions may prevent a patient to come back to the ER, a bit like the patient engagement system like Seamless MD or another resources. Patient at home may have anxiety, questions, they see their dressing with blood and they fear there is a problem ongoing. But if you have somebody to answer their question and reassure them, you may prevent what I call failure. Did you have somebody at your hospital in Toronto available to answer patient question? Do you give them a phone number to call back in case?
Yes, yeah. So there are people that are like a hospital coordinator, etc., that patients can call, and that coordinator will offer the patient advice, and they'll usually speak to the in-house who's on call as well. And I'm then informed, and I contact the patient the next day, or if I'm on my email that I might contact them then. I think the concern, what I've noticed sometimes is if a patient is inappropriately educated, sometimes they can't even describe what they're going through adequately, and then everyone defaults to, if you're not sure, please go to the emerge, and then you kind of lose all the things. So what I found has made the biggest difference is really educating the patient right from the start, so they have a better understanding of what to expect.
And maybe what you saw, all these, the rise of return to the emergency after outpatient surgery, is that in a period of COVID, people tried to do outpatient surgery without modifying much what they were doing and expecting a miracle to happen. The key here is that if you really want to succeed, you need to modify the traditions, the way you were doing surgery, anesthesia, post-op care 20 years ago, 15 years ago, and then you will improve the success rate of the outpatient protocol. Do you agree with that, Dr. Ravi?
Yeah, definitely. No, I think that makes a lot of sense. You can't do what you've been doing and expect the results to be the same. This is an entirely different patient stream, and you have to change, basically. Yeah.
Great, thank you. I think we'll move on to Dr. Hardy next.
Okay. Thank you very much. So next is probably, to me, a very important topic tonight. Patient satisfaction should be one of the goals of any outpatient program. Outpatient program has a lot of benefit for the hospital, has some economical value, but at the end, we should keep in mind that patient satisfaction and good clinical result is our goal. So Dr. Hardy studied that aspect and published a paper on the pillars of patient satisfaction. So Alexandre, please take the screen.
Thank you, Dr. Vendittoli. Do you see my screen? Yes?
No, we just see an orange bar.
You don't see the screen?
No, unfortunately not.
Do you see it now?
Yes, it now works. Thanks.
Okay. So hi, my name is Alexandre Hardy. I'm an orthopedic resident at Université Laval in Quebec City, and today I'm going to present to you patient satisfaction experience and why it should remain our main goal in total joint orthoplastic programs. I have nothing to disclose. So first of all, what is patient satisfaction and experience? Well, patient satisfaction in the context of medical, in a medical context is quite, it's a congruence between the health service provided and the patient's need, desire, and expectation. So, and also satisfaction can be divided in two groups. And first, you have the determinants of satisfaction, things that are intrinsic to each patient, like its age, gender, comorbidities, beliefs, expectation. And then you have the components of satisfaction, things that as a healthcare provider, we can have an impact on, like the interaction they have with the staff, the interventions we're doing, the outcomes we provide, or the environment we provide either. And then what is patient satisfaction? Well, when we look at patient experience on the other end, it's a more complex concept. It's the sum of all interactions. It's shaped by the organization's culture that influence patient perception across the continuum of care. What it means is during a care episode of total joint arthroplasty, it's the patient perspective on its health, its well-being, its quality of life, how is dignity is respected during that episode, how he can keep his independence and autonomy during a moment when they lose, at least in the post-acute period, some of it. And then why is it important? The NHS in the United Kingdom described it the 3 pillars of quality of care. And we're very knowledgeable in the first 2, which is patient safety and clinical effectiveness. As clinicians, we're used to assess those and look for those and try to improve those. But the third one is patient experience and satisfaction. And it is as important, if not more important, than the 2 previous ones. Some studies have shown that these 3 are very well linked. And if you enhance one, you enhance everything. And so that's why patient experience and satisfaction is important. And then how should we assess it? For satisfaction, we can assess it like most of our other outcomes. We can use patient-reported outcomes. Some are standardized and widely used, like the CAHPS. And you can also look at the satisfaction from different perspectives. You can look at them from an overall perspective, or you can subdivide it in different components of care, like, are you satisfied with pain management? Are you satisfied with your recovery, etc.? For patient experience, it's because it's a more complex concept and it's from the patient perspective. You can use some pros, some surveys, but use some open questions. Let the patient have an opportunity to tell you their story from their home world. But the most validated format is usually interviews. You can do individual ones or some focus group. That's what's being mostly reported in the literature. And then, how is patient satisfaction and experience with ERAS outpatient programs? Well, the systematic reviews that were done in the last few years show that the satisfaction is relatively high and similar between inpatient and outpatient total joint arthroplasty program. You can see the range are similar in between inpatient and outpatient programs. And as we know, the satisfaction is usually a little bit higher for total hip arthroplasty compared to total knee. And then we did a little research 2 years ago that we took people that experienced both protocols. So they had a surgery like a total knee arthroplasty with the inpatient program, and then they had the other knee done with the ERAS outpatient protocol. And we asked them to compare their experience regarding their satisfaction. And in general, people were more satisfied with the ERAS outpatient program, but they were also more satisfied with the time they passed at the hospital, with the pain management protocols that were put in place, with the ease and speed of the recovery, but they were also more satisfying of the wound closing method that were used. And then we also asked them if they had to recommend one or the other, which protocol they would recommend for another total knee or total hip replacement. And the vast majority would recommend the ERAS outpatient protocol compared to the inpatient one. And then we did another study at the Maisonneuve-Rosemont, and we look at the patient experience. And the main theme that emerged from the interviews was that support was crucial, and support throughout the entire component of care. And one patient stay, I think, said the best. He said, support make the difference for better and for worse. So that was a main theme that was retrieved for almost all patients. And then we found some difference between ERAS outpatient programs and the inpatient. And patient said that the ERAS outpatient program enhanced their experience because it reduced the post-operative inconvenience, like they had less adverse event. It also optimized their pain management because they were able to manage by themselves more quickly their pain medication, but also because they had different type of medication that caused less adverse events. They were glad, very satisfied to return home sooner because, like a patient said, home is where the heart is. And I think that the best place to kind of relax and after surgery and do your rehab is at home. And then people were happy, and they report that they had a faster recovery with the ERAS outpatient program. I'm going to share you testimonies of two patients. So those patients had both inpatient and outpatient experience, and I'm going to share it with you.
What was mainly the recuperating time? It was just much faster with the on the left knee. Like I mentioned earlier, I was walking with a cane probably 5 or 6 weeks after the operation on the right knee, and within a week after the left knee operation, I didn't need a cane anymore. So, and there's virtually no pain in my knee at all.
Did you have to take some pain medication for the left knee?
Yes, we took Tylenol.
Tylenol?
Yeah.
I think the physiotherapy, did the physio told you that you were faster with one knee versus the other?
Yeah, the left knee, she said I'm 6 weeks ahead of where I should be right now.
6 weeks ahead of the your schedule.
Yeah.
Okay. You had a problem with your right knee because you were unable to avoid and to go to the bathroom for more than a day.
Yeah, from the anesthesia, and from the anesthesia on the right knee, I was almost a day and a half before I could urinate, and on the left knee, I was in the afternoon because I was operated on about 11 in the morning, and 3 or 4 in the afternoon, I went to the bathroom.
Okay, good. So for you, the overall, you believe there was some benefit of having the procedure the way it was done on the left side?
Oh yes, no question.
So if you had a third knee, which one you'd select?
The left knee. And also only one day in a hospital, it makes a big difference too.
Okay.
Because you rest much better at home. What was
So you had the left hip done with a rapid recovery protocol and the right hip a few years ago with a standard procedure.
Both recoveries were quite good. However, the new one I just did, it was fantastic. I was ready to go right away. I didn't take any painkillers. After a week for the second operation, I was done with the crutches. I didn't need them. The first operation, I think I was using it for about a month. The physiotherapist that was coming to my house, she was like amazed. Like I was in no time going up and down the stairs, and I had full mobility almost.
Did you experience some nausea, dizziness, hypotension? Okay.
Not at all. I was in great shape right away. Like I had no pain. I literally had hardly any pain whatsoever. My physiotherapy that I did for the month, I was doing everything. No, there was no pain. The progression was really fast. I'd say the rapid was the best experience.
So you had the left hip.
So, and then how can we, as healthcare providers, how can we improve patient satisfaction and experience? Well, first of all, we need to assess it. And to assess it, the best way is to have the patient feedback. You can have it through survey, testimony, interviews, or you can use a patient partner approach or either focus group, but you need to find a way to get the patient feedback and point of view, and then you need to apply it. And like in our study, one of the things that patient mentioned, it was we need to improve communication between hospital and home care teams, because sometimes the message were different and the recommendations were different. And that create anxiety and some visit to the ER that were unnecessary. And then another thing, like Dr. Ravi said previously, we need to make a resource person easily available for any inquiries. And that's the kind of support that the patient needs and required to have a great experience. And then the pioneer of ERAS protocol, Dr. Kellett, like he said in his initial papers, said, first do it better, then do it faster. So our main goal should be to optimize patient safety, clinical effectiveness, but also patient satisfaction and experience. And then when everything improves, it will go faster to the point where it's going to be a same-day surgery. And then we, as different stakeholders, we all have different point of view and objective. Like administrators want to reduce costs. Professional, we want to do our best, do more case. But patients, they just want to have a faster recovery with no pain. They don't want any adverse effect. They want to be satisfied, have a great experience. And I think as clinicians, we need to keep in mind that our protocol and all our programs have to focus on what's best for the patients from our point of view, but mainly from their point of view, what's going to benefit them. So my take-home message are the next. The patient factor of satisfaction may be different than the one of different stakeholders like us, doctors or administrators. A great patient experience and high satisfaction is primordial to result in high quality outpatient total joint arthroplasty program. It's as important as improving patient safety and giving a great effectiveness of care. Support. I think it's key throughout the episode of care, from the first appointment to the last follow-up. I think every staff member is important, and we need to make sure we convey a same message and everyone works hand in hand to give the best care possible. And then finally, when we compare our ERAS outpatient program to standard inpatient, we found that it improved patient experience and satisfaction. And I think we still have something to address to make it better, but it's certainly a step in the right direction for the patients.
Thank you, Dr. Hardy. So next we'll take just a few questions for Dr. Hardy, and then we'll open it up to the group. We do have a 20-minute Q&A session at the end. So our first question is, how soon after surgery do you do the survey, and do you follow up after some time?
The survey was done as part of a research project. I don't know if Dr. Vendittoli, you do it now for every patient you do as an outpatient program.
I'm not sure about the question and what they talk about survey, but patients are seen by a nurse from the CLSC local clinic about 3-4 days after surgery, and the physiotherapist will see the patient also in the first week after surgery. And if patient needs to communicate with a team member, this is open anytime. They will come back and meet the surgeon, usually 4 to 6 weeks after surgery. So, as Dr. Hardy mentioned, I think the most important part for the patient is to feel that there is always somebody available for them if needed. Patient needs people, and this is very reassuring for them.
Thank you. And I just got some precision. It was about a satisfaction survey.
satisfaction survey can be done anytime after surgery, and it will change over time. We like to test patient satisfaction after, let's say, 6 weeks, 3 months, 6 months, and a year, and you will get a different perspective from the patient. Early on, it's really all the peri-operative care, and later on is more about the clinical success of the procedure.
Thank you. And do the patients having same-day surgery get home care physio, or do they go to outpatient physio clinic?
They get the same home care physio as people who went inpatient program. So in Quebec, it's the CLSC provider that physiotherapist that goes home and provide the exercise and rehab program.
Interestingly, this was really a concern when we start outpatient, that physio and nurse care should be more, let's say, intense or more rapid after surgery. And in fact, as it was mentioned in the 2 testimonies, the physio, when they go home and see an outpatient patient, they say, "Oh my God, you're already walking with a cane. You're doing great. Oh, maybe I'll come back in 2 weeks." So in fact, the home care is reduced with because we improve outcome of the patient.
Thank you. Our next question is there any physio follow-up done by teleconsultation?
I think Dr. Vendittoli, maybe you're more able to answer this question, or Karina.
It is something available in some center. It's with Zoom, a video conference. It makes tele readaptation a very interesting tool. So really, it's up to any center to decide on the best way to provide the patient care. Having a wound problem today is easier to manage at distance. People can send a picture, we can do a live video, and the patient can tell us where is the pain, how he can move his knee, his hip. So it makes our life much simpler and also for the patient.
Thank you. Okay, let's open up the floor. We'll invite all our panelists to now answer all of our questions. And I'll just make sure that we can include everyone here. Okay. Great. So I'll start with Dr. Ravi. When implementing your patient application, did you experience resistance from surgeons? If so, how did you overcome this barrier?
Sorry, when looking at what?
Oh, sorry. When implementing your patient application, did you experience resistance from surgeons?
No. So I should add that it was initiated before my time, and as it was rolled out, I think it's from my colleagues at our hospital, it's had a lot of support. I think we've all contributed. Some of us have contributed to it, especially around the opioid part, etc. So no barriers. We did find, as I've mentioned, that as patients have become more savvy with their phones, or maybe the different cohort is aging into the time for joint replacements in their life, we're seeing significantly more uptake. But no issues with convincing other surgeons, etc.
Thank you. Dr. Vendittoli, I presume that the TKA patient seen in the video had both knees kinematically done?
Most probably, because I started in 2011, so for all my patients, so I assume yes.
Thank you. And this is actually just a good comment here. I thought that could get the discussion going, a bit of a devil's advocate perspective. The anonymous attendee says, really interesting and inspiring, but you seem to have an unlimited access to unlimited outpatients resources. This is not the reality in many, many regions, and shortage of personnel would be the main obstacle to implementation of an ERAS protocol, I feel. Any thoughts on this?
I think it's this is a perception that it needs more personal, more involvement. The main for me is really a reorganization of the care. All the people that were working on the floor, now you need them to be oriented on this outpatient program. So it's just a reorganization of resources. Physiotherapy should be available for discharge, so change in schedule. Nursing care, instead of being on the floor, should be available to do pre-op education and post-op, let's say, availability to answer patient phone calls. So it's I don't believe it's more work, it's a different work. So it need the leadership, and as Debbie mentioned, the teamwork is very important. And looking at champions hospital in each provinces is something very interesting to motivate groups to do better. Now in Canada, we have great centers achieving good results, and we should view this as something, a motivation to do better.
Thank you. Any other comments regarding this?
Well, I
I
could
just-
add, like, oh, sorry, Debbie, go
No,
ahead.
go ahead. C'est bon.
I would just like saying, yeah, we are missing resources, of course, and some physical therapists beginning don't want to work at night. It's like, it's not a dream, I mean, working at night. But when you coach people and you just tell them what it is and it's helpful for the patient, sometimes you get them in, and as coaching and helping them, knowing what to do, sometimes you get people in and just happy to help and just saying, okay, it's patient satisfaction. So, okay, we'll help the patient, we'll get there, like we'll work nights, maybe not every night, and we share the night shift. Like I used to do it all the time, now I'm sharing my shift. Like sometimes people are doing it for me because I go on vacations and I'm off sometimes, and people are getting in because they see that the patient is doing well after. We are not all available all the time at night, so it's a teamwork. And yes, you need to get people involved, and you need a leader to just get them in and involved, of course.
If I can talk for my area, I mean, we've had a pre-op clinic since the 1980s, I think, so that hasn't changed much. In our PACU, all our day surgeries, all of them, no matter if they're total joints, they are all called the day after, sorry. And I really think that we did not shift more. We just didn't say, okay, you're going to go home on the day of surgery and overloaded the clinics outside. I think we were very much, it does not happen like that. I mean, physiotherapists do not have to see more patients because they're leaving on the day of surgery. That is for sure. Anyway, not in Quebec. That is for sure.
Yeah, we see the same amount of patients, but we leave later. That's the only difference.
Thank you. I'm not sure if this is applicable to this discussion, but there is a question about, were there any problems with the unions when modifying hours?
Is that for me? Because the union is there tonight. Well, it depends. It's managing. It's the hours of a physical therapist can be changed in the hospital. So no, but there were a few questions about that, of course, because some of them were working from 8 to 4. Of course, they might be involved, but it's a managing thing from the coordinators and from the rehab team. So the hours of a physical therapist actually are days hours, and we can work at night. Even if the union is involved, the hours of a physical therapist are all day. I'm talking for Quebec. Around Canada, I don't know. But for us, the hours can be changed. Like we could work from 8 to 8.
And I know throughout Quebec, because I'm involved with the implementation of ERAS program throughout Quebec, for the physiotherapists, some hospitals ask for volunteers. And some people did prefer to work 10 to 6 or 11 to 7. I'm not saying everywhere, but there were volunteers that stepped up and say, yeah, I'll try that shift.
That's interesting. Thank you. Okay, going on a new tangent. how do you measure anxiety levels that would exclude a patient from day surgery?
In the pre-op assessment, they are patient on known with psychiatric disease. They take drugs to reduce anxiety. It is not let's say a clear exclusion criteria, but we can identify these patients as a risk. And working with Karina for years, she was seeing all the patients, and after numbers of patients that you see passing through the protocol, you say, oh, this patient will be a tough one. And sometimes we're surprised they do well, but the most favorable factor is their environment. If they have a caregiver with them, reassuring, then you can work in partnership. And I think, I don't know, Karina, if you can share your experience, but the pre-op meeting is very important to get this feeling of the success of these anxious patients.
Yeah, when you first begin, it's good to just meet the patient one by one. That's what we were doing at the beginning. As we grew, we were doing it in teams, like there were a lot of patients all together. And when you look at their file, you question the patient, you look at what they're taking, you get a sense of how they live, how they react, sometimes also with the family around, with the question they ask you, and just being part of an hour with them is usually good. I know there are a few questionnaires about anxiety, and just to pinpoint patients that I don't have them in mind right now, but I know they are. Debbie, you're saying yes. Maybe you know the names of those questionnaires and we can find them for the people asking the questions. But there are questionnaires to know the level of anxiety of a patient and to be able to just include or just exclude them depending on the results.
Yeah, there are validated tools, but I don't think these validated tools are given automatically in a pre-op setting unless you're doing a research on it. Then I forget the name of the tools, but
yeah, if you have a question on a patient after a meeting with them and just seeing how anxious they are, might be a good patient if they're too anxious. So you have an idea if you want to do a questionnaire only for that patient. Sometimes it could help you. Not every patient, we don't do a questionnaire with all those patients. Of course, we don't have time for that. We're just spending the time with the nurse, that's spending the time with me in a teaching group, seeing them, because it's half a day they spend with us before the surgery. They see the nurse, they see the doctor, they see us. We talk to each other and we get the feel of the patient. And if we have questions, we just talk to each other and say, maybe it's not a right fit for that person.
Thank you. Okay, moving on to coordinators. Is your coordinator an advanced practice nurse, an NP? How much are they involved in direct patient care?
I think they're in general nurses, but for this specific program, I don't think they need to be nurses. In general, when you talk, if you go under the ERAS Society and they talk about the team, it's usually a surgeon, anesthesiologist, and a nurse. It can be any nurse, really, but if you want another type of coordinator, especially for this program, a physiotherapist could definitely be a coordinator for this specific program.
I was one at Maison Small when we first started. I was the coordinator of all the program. I was going in the OR. I was there before surgery. I was taking care of the patient after. I was the one they were reaching, calling if they needed anything. I was doing it, and I'm a physical therapist. And at the time, I did not finish my master. I was implementing the program.
Thank you. Okay, and are there any recommendations for physical therapy preoperatively to improve mobility and accelerated rehabilitation postoperatively?
There are a few guidelines. I don't have them right now with me, but there are a few guidelines to help the patient get better after surgery with strengthening and range of movement. Doing physical therapy and exercise before surgery is always better because they improve faster. So of course, there are exercises they can do specifically. In Quebec, we don't see them for exercises before surgery. We see them for equipment from the CLSC before we see them, but the patient is always told in our teaching class that if they need more, they can reach out and go see a physical therapist before surgery. And of course, if you have good mobility and good strength, it helps after surgery to get better.
Thank you. Dr. Vendittoli, when selecting patients, do you talk with the caregiver, and how much influence do they have?
Personally, when I meet the patient pre-op, it's in like a regular orthopedic consultation. I try to get a feeling of the motivation of the patient to do the outpatient procedure. If they are accompanied by husband, wife, kids, then I can get a good feeling. And most of the time, the patient that we feel will not be a good candidate is the one that tells you first, I'm living alone. I have 20 steps to go to my apartment, and nobody will take care of me after surgery. So these are probably the most common patient that I need to exclude from my outpatient patient program. In fact, all other patients who have some partners or people ready to help in the first days after surgery, they're good candidates.
And
Thank
we
you.
need them when we teach, like they get in the class, they're sitting next to their partner or family member or anyone that is there. The family is invited in the teaching class. So we see them. They get to know what the patient's going to go through as well.
Thank you. So that's all the time we have for today. I was wondering if we could just go around the room, if you have any last pearls of wisdom you'd like to share, and where people can reach you if they have any additional questions.
I can start. So, I'm very, very happy about the content of the webinar today. It was different than talking about general principle of outpatient ERAS. We went a bit more in details. And for sure, I think all speakers are available to answer questions. Maybe Rebecca, people could reach us through the COA, and you can provide my email without any problem. So thanks, Debbie. Thanks, Dr. Ravi, Dr. Hardy, and Karina for being part of the webinar tonight. I think it was very helpful. I don't know if you have something to add to close the meeting.
But I would say, don't worry about the hurdles. Just do your best. Think about patient satisfaction. That's what we are there for. So don't worry about the hurdles and do your best.
Thank you so much to all our speakers, and we hope you have a great night.
Thank you.